Good afternoon again, everyone. I think it's time to start now. More people will join on as we continue. My name is Dr. Gomolemo Smith. I am an employee of the Ministry of Health. I'm currently doing my master's in public health medicine at the University of Botswana. I'll be sharing today's webinar. So thank you very much for joining today's webinar. These webinars are organized by the University of Botswana in collaboration with the Botswana-Rutgers Partnership for Health, together with the Ministry of Health. So these webinars were created to equip healthcare workers who are in the front line with the knowledge, skills, and the tools that they need to combat COVID-19 and to be successful in this COVID-19 response. So we have these webinars weekly, almost weekly, sometimes due to unforeseen circumstances, we are unable to have them, but the idea is to have them every Thursday. Like I said, it's a co-organized webinar series by the three partners. The four partners there, I forgot to mention Botswana-Harvard partnership, my apologies. So if you want to receive the invitations to the webinars every week, what you can do is you can send an email to Vusi at vindaba@globalhealth.rutgers.edu, and you'll be added to the mailing list to receive the invitations every week. So these sessions are over Zoom. They are recorded, and you have an opportunity of looking back at the recordings, because from here they will be uploaded onto the Botswana-Rutgers Partnership for Health YouTube page, where you are able to access this webinar as well as other previous webinars that you might have missed or that you'd want to look back at. Okay, so we also have the COVID-19 portal, government portal, which has different relevant documents in relation to the COVID-19 response. So there's a list of about 22 guidelines on that government portal, and you are able to just freely access them by going on to that URL at the top there. So we have about 22 or more guidelines on the COVID-19 portal. Today's session really follows after a presentation that was done about 2 weeks ago by Dr. Moyo, which was on the variants of concerns and the variants of interest in Botswana. And he had mentioned during his presentation that the Delta transmission clusters have been identified so far in Phalape, Gaborone, Ramotswa, and Kasane. And that is why we saw it fit to invite today our speaker, who is Dr. Clement Mukadi from the Chobe district, who will be presenting on their experiences in the COVID-19 response in the Chobe district. So Dr. Clement Mukadi is currently working in Chobe, in the Chobe DHMT as the head of preventive, and he's also the incident manager of their COVID response team. He did his medical degree in the University of Lubumbashi in DRC in 2008. He has also been doing a master's in public health with the University of Johannesburg, which he has been doing since 2018 and is currently awaiting graduation. He's also worked at the Sakuma Memorial Hospital in Sorowe, in Kachikau village, still under the Ministry of Health. And like I mentioned, he's currently based at Chobe DHMT as the head of preventive and the incident manager. So Dr. Clement Mukadi, the opportunity is yours to present. Thank you.
Good afternoon, colleagues. Good afternoon, everyone. Let me take this time to appreciate and for the opportunity you have given us as Chobe DHMT to share our experience for this pandemic. I'm not alone. I'm with my coordinator, is Mamunyere. I would like also to direct my appreciation to her to have made this easy for me to represent the district in this forum. Next slide. Okay, this is just to show, this is the current situation in our district. We have is a new development of the bridge, which actually is connecting Zambia to Botswana through Kazungula. So it's just trying to highlight, as you may see, an impact as we present the next slide. Next. For those who don't know Chobe district, where we are located, we have a special setting in the region where we share our borders with 3 neighbors countries, which actually is Namibia, Zimbabwe, and Zambia. And this is sometimes make the situation a bit complex of sharing these borders close to our small district with an average of 29,000 population. Next. This is This is the background of our situation. As I said, we are sharing the border of 3 countries, and the nearest facility or nearest towns from these 3 countries are Katima Mulilo, that is Namibia side, Kazungula, Livingston, this is Zambia side, and Vic Falls, this is Zimbabwe side. Our population is by projection of 2021. Chobe represents 29,805. We have 7 villages, we have 17 safari camps, 16 major farms, and 5 active point of entry. There are more, but those actually concerning the COVID, we have 5 active, which is actually a bridge, road, Ngoma, airport, and the regional point of entry, which makes 5. We have 11 facilities, and with 1 primary hospital. The remaining, we have 1 24-hour clinic, and the remaining are up to half 4 clinics operating up to half 4. And we have also 3 private facilities or clinics in the district. Next. So just to start, this is the general situation of the statistics for the COVID. As you may see, we have divided our slide or our presentation. It comes to the statistics in 4 levels. We have cases, the person, test, and vaccination. And these are indicators we are using to control our outbreak or the disease. As for the last 24 hours, we have recorded the 37 new cases, and the active case, they've gone down up to 395. And remember, this is from the 7th of July. We had reached up to 2,061 cases active. And our cumulative number right now, we had 6,813. When it comes to the person, what have you noticed as a statistic that we have recorded 1 death for the last 24 hours, and our total now stand at 31 deaths. And our recovery rate is at 93.4%. We have also some people who have been repatriated, actually, mostly truck drivers who prefer to go back to their home country with collaboration with our neighbors for smooth repatriation. For the past 24 hours, we have tested 300 clients with the positivity rate of 12.3%. And we have performed 88,164 tests done for COVID. This is combined PCR and rapid. When it comes to vaccination, as part of the response to the outbreak, our targets for vaccination above 18 years is 18,318. This is the target we are trying our best to achieve to control the disease and to reach the herd immunity in the district. And for those who have received full vaccination or full doses, first and second dose, because here we have given so far AstraZeneca and Sinovac. So those who have received the full vaccination, there are 1,552, and this represents only 7.4%. Those who have received one dose, 1.6. That is the average. At the end of all this, the message is the key message to everyone is that the COVID is real in the district, and we are there to comply to the prevention, such as masks, social distancing, maintaining the distance, and to vaccinate when the opportunity is given to save lives. Next. So we're trying to map our cases in the district. We divide our district in three catchment areas. We have what we call Chobe Central. For those who have been in Chobe before, this takes from Lesoma up to Plateau. And we have Chobe West, where we have from Mabele up to Parakarungu, we have 5 villages that side. And we have Pandamatenga. Now, when it comes to the cases, most of the cases were concentrated in the central, and they represent 88.9%, and while Chobe West 7%, and the least is Chobe East with 3%. And remember, of this 3% is only one village, and the 7.4%, this is actually 5 villages. And this is how our cases are scattered. You will see in yellow, these are the cases by each of the 7 villages. But the most affected is the Chobe Central, as you can see, hotspot. Next. So this is our positivity rate. We combined only for the past or for 2 months from June to July. This is when we started a new wave. Since April, when our situation were down, unfortunately from June, end of May, June, we noticed a resurge of cases. And this positivity rate is representing only the period of 2 months from June up to now. You may see that our positivity rate is trying to go a bit higher, but this is not a true reality now because the cases are going down. It's not that when the school were closed, from the 16, the school were closed, and this reduced our denominator of testing. Remember, for the school children, once one is positive, you have to screen almost all the students in that classroom. So it was mostly increasing our denominator and reducing the positivity rate for to 16.1. But as you may see, we are going to expect this for the next two weeks from the time the school were closed up to now to see the impact of the school cases. Next slide. Okay, this is our cases per month. Allow me to say that as Chobe district, we recorded our first local case, it was August, where we recorded 2 cases. And from there, we went up to December, where we recorded the highest number was 11, and that was the end of the year. And from there, there was opening of the border. In January, we had our first set of cases where we recorded the case up to 187, only for 1 month of January. And this is local cases. As you may see, everywhere they are imported and local. Why important? Because as I said, we are having a special setting in the district where we share borders with other countries, and we find it is necessary and important to mention the imported cases and how it impacts on the local cases. From there, we had the highest number was March, and this is it was the end of the wave, 314. The case, we managed to control the situation until end of April, where we had only 46 local cases from 300. And the last 10 days of May, we noticed another set of cases, which actually get aggravated or worsened in June. Went up to 2,351 cases. And actually, as of yesterday, the month of June, we have recorded local cases 3,269, while the imported cases are 73. It shows that the imported cases also have started dropping, but the local cases are still in an exponential increase. Next slide. Okay, this is we have combined our daily cases on this slide, our daily cases and the 14 moving average. In blue, these are our daily cases. You see that the highest number we had from the first wave was 32 cases. But for this current one, for the months of June and July, we had recorded the highest number as 266. You may see the curve, you may see the top, but that one you don't, we don't consider that highest number of 394. This was for 2 days. That's why it looks like it's higher than 266. But we have to consider in terms of daily data, daily positive cases, the highest number we got for the district 266. And the case continue dropping up to today, where we are going with, as I said from the first slide, that as of yesterday, we recorded 37 cases from 266. Next. Next slide. Yes, that is the orange line. I try to separate from another slide. It's showing our 14-day moving average per 100,000 population. You may see as of today, we are at 52 day cases per 100,000 population. It is still high. It is still above 50 cases. But it means we still in the white color or red is we have to take for the district for the region as a district, but not as a zone. And to us, despite still in the high number, there's an improvement. You can see the curve, how it's dropping. There was a time went up to 577 14-day moving cases per 100,000 population. And from there, it's almost half of the decrease. But this, it brings us to, our analysis is showing that every week, we have a drop of almost 26% from weekly analysis data. Next. Okay, the health system was also affected or still affected as we speak. Our frontliners from the different departments where all this, they are first responder to the outbreak. Our nurses were affected at a high number, at 85 cases. The support staff, this includes the drivers, the orderlies and the cleaners, 59. At the point of entry, our environmental health, 5 of them out of 13, and our lab colleagues as well, they were affected. And so far, 3 doctors have been diagnosed with COVID. And the total for the frontline health frontliners is going up to 159. And in this slide, the most highest affected areas, you can see the patient department and maternity. So close to 80% of the staff were affected with the COVID. But the good news is that none of them, all of them, mostly they recovered without any problem. These are our point of entry cases. As I mentioned, for the active point of entry, we have them, there are 5. We're still recording some cases from the point of entry as airport. The airport mostly are the flight from outside of the country, and they are tested locally. We do the screening through a rapid test. Everyone coming in the country, despite valid PCR, we do the rapid, and some of them reveal the positive cases. As you can see for the bridge border, the bridge I just shown, which is actually connecting us from Zambia. For the month of June, we went up to 126 cases. And these are people coming for valid PCR. When you do the rapid, they turn back a positive. But we've noticed also a decrease of close to 60% from June to July. And this is through our collaboration with our neighbor country, how to do the surveillance at the cross-border level. Next slide. Then from there, all the cases, we collected some sample randomly, and the total for the result we received from the sample taken, there were 80 sample for sequencing at the national level. And from there, out of the 80 sample collected, 50 of them turned back as a Delta variant. And when we tried to analyze according to the time, this actually started from June to July. At the beginning, some of the cases were collected sampled at the beginning of June, some in the middle of June and July. And I'm sure if you keep sequencing, you will get more as you are ending the month of July. And our distribution per age of this variant, we have noted the average all the patients, they were from 2 months and 89. So we had the youngest child who was actually 2 months with a Delta variant, and the oldest was 89. And most affected young generation, less than 45%. And among our recorded deaths, we had 2 who had the Delta variant. When it comes to locate them from the areas where the cases were coming from, most of them were coming, some were from the point of entry. The first case of the Delta variant was from the Zimbabwe side, which you call the road border. And some were from a bridge border. And we noticed a high number in schools, in the boarding schools actually. And most of them, they were female students. And it went sometimes even in the primary schools as well. And for the boarding schools in the district, we have 2 boarding schools, Kachikau and Kasane. So the 2, they were identified with this new variant. And when it comes to the community, the most affected community in the area, remember I said we have 7 villages, but the most affected in these cases were reason why Kazungula was highly affected by the Delta variant compared to other areas in the district. Next. So we try to map our cases. You may see that there is a Kachikau, 6. That is the number we got from the school, and it's a senior secondary school. It is a senior secondary school. We recorded 6 cases. Among those, random sampling, and Plateau, we had 12 cases, and Lesoma, we had 1 case. But the interesting thing is from the point of entry, you see only from the point of entry, we have 12 cases. And when you mention point of entry, even the colleagues, some of the colleagues who are working there, not only those coming from outside the country, even the colleagues who are working there, some of them were detected for the Delta variant. And our suspicion could be, because these are people who are swabbing and testing all the entry in the country. So they will be exposed by the variant. And you see Chobe Junior Secondary School as well is the most hit compared to other schools, 12 cases among, and most of them, they were they were girls. Our investigation to see how could this happen. The reason or the finding were that from the point of entry and other areas, as I will say, we have 3 neighboring countries. Most of the truck or other travelers are concentrated at the way bridge at Kazungula. And most of them, they go and shop, they go and shop in the mall around. Because that one case from Lesoma actually is just working in the mall, facing the parking lot of the truck drivers and other travelers who are waiting for the result. And we thought this could be the reason, the interaction at Kazungula could have been the reason or a risk factor could have exposed the community. And in Kachikau, we have the teacher, 2 teachers actually, who traveled to Kazungula for funeral purpose. And when they went back, there was an outbreak in the school. But unfortunately, we did not pick their sample for sequencing. We just did a random selection. We found out there were 6 students, but there were no sample for the teachers who tested actually positive. And remember, this analysis, some of them we have done after the client have recovered and out of the isolation. Next slide. We have recorded so far 31 deaths in the district. And if we have to separate it per month, from January up to now, the first death, remember our first case of COVID was in August 2020, but our first death was in February, followed by another case in March, April, and June we had only 4 cases. And it has, from then, the case was an exponential increase of mortality cases. We went up to 24 cases. So for us, it may look like it's 24, it's a small number, but this number speaks a lot to us. Looking into our population, the population, the size of the population is a high number. And the case fatality rate per month, as you can see, April it shows that it's the most hit, but we had only 1 case. The reason being that was the number of positives by then, we had 46. So it's a small denominator to give us a high number of case fatality rate. But as it stands today, we are at 0.9 case fatality rate. Compared to June, we're at 2, and we are going to observe as we go on how it may drop, and we are sure it is going to drop. Next. According to age group and gender, the most affected, not the most, actually the difference is not significant. We have 15 females and 16 males. It's almost 50% each. And the youngest among our clients were 23 years old, and the oldest was 97. Remember, that is for mortality cases, not the general positive cases. And we try to compare the age group as well. You see that from 36, the age group the most affected was 36 to 45, and followed by those above 75. So this is the distribution per age group. So 23 to 35 is 4. This slide just shows that the COVID mortality is not the matter of the elderly as we were thinking before. Actually, everyone is at high risk. Next. Okay, we analyzed also our death cases according to comorbidities or other medical conditions. Those who were most affected, those who have a cardiovascular conditions such as hypertension and the cardiopathy. And most of them, they had combined cardiovascular disease and diabetes. The HIV, we had only 2, and obesity, 6. The remaining 10, some were unknown, having medical condition, some did not have any condition. The interesting between our mortality and vaccination, you see that we have recorded more than 1,000 fully vaccinated. And among them, we have 0 deaths among the fully vaccinated. And those vaccinated, given 1 dose, we have only 4 cases out of 31. And mostly the deaths occurred among unvaccinated clients, which means this slide, can you go back? Yes, this is actually the slide we are using to try to convince some of our community or our colleagues to get vaccinated. As you may see from the result that the vaccine plays in a big role in the control of the disease. Next. Most of our patients in isolation, 90% of them are in home isolation, only 10% are in the facility isolation. The question is now is how do we respond? How did we respond? How are we going to respond again on the outbreak? Because you are still in. So first thing we did was to do the risk assessment. Why did we have many cases? Why do we still having people dying from COVID? And our risk assessment, we directed the 3 levels. We assessed our schools to see what, because at the beginning, most of the cases were coming from schools. And we have to go all the schools around the district to try to find the gaps and close them to reduce the chain of transmission and to break the infection triangle. And our health system, why are we not managing some of the cases, why the transmission is still ongoing? So we had to investigate or to assess our health system and the community as well to see if they are complying to the guideline, the protocol of prevention of the disease. Next. After risk assessment, this is what we have come, or what we have done, what we are doing, and what we will continue doing. So we decentralize all the surveillance system. From the contact tracing, we said all the health facilities in the district, they should own the response, not even centralized at one point in the district. We had to train the government, some of the government department employers on the contact tracing, such a way that if there's a case in a certain department, they are able to do the contact tracing instead of waiting the DHM to the health to come and do the contact tracing. And the delay within 24 hours, if we don't reach the target, it means the control of the disease become a challenge. So we had to increase the number of the testers. Under surveillance, we have trained the other community members, such as, or NGOs, such as the developers, so that they can assist in the surveillance. Actually, there are some categories of the population we don't have access to reach easily, such as key population. Remember, I mentioned the issue of the truck grounding at the bridge or at Kazungula. And you know, our sisters and brothers, some of them, they go for a little business there. We call them key population. So we don't have access to them. We have involved the developers that are part of us or the response to see how they can achieve this. And one of the things under surveillance is to achieve the targets of 888, which means the 80, we have to isolate all the positive cases within 24 hours. We have to trace the contact within 24 hours, and we have to test all the suspect or the contact with at 80% within the first 24 hours. But the good thing for our district that mostly our average were at 90 to 100%. This is because the system or the contact tracing was decentralized. Okay, let's go. Next. Oh, sorry. Can you go back a bit? Yes. At the point of entry as well, we keep doing our screen through a rapid test. All the point of entry. I mean, all the travelers coming in the country, despite their valid PCR, we repeat our rapid. We do every 2 weeks testing the staff. Remember, I showed the bridge. That bridge is a one-stop border. It's one-stop border. It means our colleagues from Botswana, they go and work Zambia side, and the Zambia side, they come and work Botswana side. So this interaction and exchange, we decide to be testing all the staff moving every 2 weeks before going and while coming back. And this has helped us to detect some of the cases earlier those who went for working in Zambia side on their back way, we managed to detect the cases. And we have a good relationship with our neighboring countries, the health authorities from Zimbabwe, Namibia, and Zambia, even in the case of repatriation or any other concern on the result, because sometimes some people may bring the fake result, but we do communicate our counterpart to try to trace. And this has helped a good surveillance at the point of entry or cross-border initiative. Next. So when the COVID started, we did not have a isolation center. We had a few cases, and looking at our district, we had only 2 rooms in the hospital for severe cases. Unfortunately, the situation got worse in June and July. We had to convert one of the isolation site, which is education center. We have converted to high dependency care, and there we admit only the very sick patients. Others, they go whether home isolation or one of the isolation public first isolation site. Another point under the responsive health promotion. So currently, those who are in Kasane or who are, you may ask, we are doing the daily health announcement in different areas in the district, where our focus is on infection control and the management of those clients in quarantine, in home, and the home quarantine and the home isolation, to educate them how they have to behave. And this is done every night, because I noticed that there's a poor compliance, and there is no way we can gather all the people together so that we teach them. But at least we are doing the public announcement every evening up to today. And our leadership or political leadership in the district, they did and are still doing also to sensitize the village leadership so that they can cascade also the message at the community level. So infection control as well in different facilities or different institutions in the district. And we have engaged the stakeholders or other members for all the development committee in the district, the councillors. They do participate at the level they can, such as giving us the vehicles for the drivers, human resources, and the facilities, even for our staff for accommodation. And the last in the response is to accelerate the COVID-19 vaccination. As soon as we receive the vaccine as a district, the following next 24 hours or 48 hours, we start our vaccination, our campaign. We don't delay, because it's part of the response. Next slide. Next. So these are some of the challenges, and we managed to overcome some, even for those who don't believe that God is existing. You'll see that Chobe is one of the districts where God has visited, because you may see how many cases we have, 2,000 cases, and we don't have an ICU. There's a lack of ICU capacity, but some of them, by grace of God, they survived. We have a shortage of oxygen, and our supplier for oxygen is in Pikwe. It means 800 kilometers to go and get the oxygen. So we have reached the stage where we have to refer some people for oxygenotherapy in other facility, and we found even oxygen in the car. But like I'm saying, by the God grace, the God is still with us and is assisting us. We have also the issue of equipment. We don't have enough equipment for case management, the shortage of staff. We don't have enough isolation space, and unavailability of the chemistry reagent for some results. You may know, when you have a COVID patient, we have to do a full checkup, blood checkup, but some we found we don't have that capacity because of the shortage of reagent. The increase of cases among the stakeholders was part of one of our challenges. Under surveillance, one of the things is the turnaround time of the result, not for the district. At the district level, our turnaround time is 24 hours. But as we have some truck drivers traveling from many borders across the country, they come and wait for the result. And some of them, they can go up to 72 hours for the result. And there is no one to control their movement. And the shop, they are just opposite the parking lot. So they cross and visit our sisters and everyone in the community and make our surveillance a bit difficult. And the lack of security at the truck parking lot is one of them. Next. In conclusion, from the first slide, we are saying we have low health system readiness. We are not ready to handle severe cases, lack of ICU. Our referral facility, Seketumile, is 1,000 kilometers. If you want to fly the patient, it will take hours. We're still recording more than 25 daily cases per 100,000 population. Health system is overwhelmed. We still have an increased trend of mortality. As I mentioned yesterday, we had one death. We have recorded a 26% decrease in new confirmed cases weekly, and decrease of cases at the point of entry, close to 60% of decrease, and decrease in terms of COVID hospitalization. So right now, the number of people admitted have gone a bit down. Next. So the way forward, we continue what we have done well from the data plan, and what we are planning to do for the next 2 weeks is to decentralize home isolation. Because those patients in home isolation, they were actually centralized at the district level or from all the villages. But from the next coming weeks, they are going to be monitored or remain under local facility, and we are going to use the existing community structures to handle the case locally. And this to us, it will help to detect the complication earlier and save life than 2,000 clients being monitored from one point. I think from there, this is the last slide for my presentation. Let me say once again, thank you very much for listening, and we'll wait for a question or comment or additional information. Thank you.
Thank you so much, Doc. It's a very enlightening presentation. I mean, we are getting to appreciate the different challenges that border communities face. So without further ado, I'll go straight to the questions so that we don't run out of time. So there's a question that was submitted prior to the webinar. It says, what is the primary clinical care need for very ill patients in the Chobe district? I think you can start with that one, then we'll go to the ones in the chat. Hello, Dr. Mukadi.
Yes, I'm with you there. Yeah, thank you very much for the question. Our primary intervention for the critical care is ICU capacity. As I did from my presentation, our referral facility is Seketumile and is 1,000 kilometers from here. It means you cannot try to go by road. If you have to use the flight, it's another process. So you cannot evacuate the patient in the next 40 minutes if you need help. So our primary is ICU capacity and equipment, so that we are the first responder to save the life.
Okay, very well said. Thank you, Doc. Going into the questions that we have in the chat. The first question was from Tuelo Mohashwa, who's asking, were the 6 cases from the school clustered? The 6 cases that you identified from the school, were they clustered? I believe this may be referring. Okay.
Yeah. Yes, I get the question. Actually, it's referring to the case what happened in Kachika. Because in Kachika we had 6 cases and 12 in Kasane, one of the bodies. So the 6 cases in Kachika, that as I said, this is yes. You can go back to the slide that I talk with evidence. Yes. So the question that in Kasika, I said, is a boarding school. These kids, they never traveled. They were just within the school. They are staying there in the hostels. So they were clustered there within the school. They're not from the community, actually. And our suspect or suspicion of contamination could be the teachers who traveled from Kazungula to Kashika, because the teachers, they do also stay within the premises. So they could have get the infection from Kasane, from Kazungula. Actually, that's where there was a funeral he attended and went back to school. So actually, these 6, they are within the boarding school.
Okay, noted. There's another question from Leila Bagirova, who's saying, thank you for the presentation. Could you please indicate which vaccines were received by the 4 patients who died of COVID-19? Which vaccines have you started giving that side in Chobe? And the ones particularly to the patients who died.
So among the patients who died, we have 4. This is why I said those who received only a single dose. And the full vaccine was now 1. So those who received the single dose, 3 of them received the AstraZeneca, and 1 received a Sinovac. And all of them, they were above 60 years old. One was 69, another one 86. The youngest was, I think, 57. 57, the youngest among the first dose. And they had also other comorbidities, hypertension and diabetes. Yes.
Okay,
And
thank you for providing more information.
Yes, one of the 4 was brought in already dead.
Oh, so one of the 4 was a BID. Okay.
Yes.
And then there are other questions from Moeso Mosukwe, who's asking, what is the role of the Red Cross in community health education to augment your efforts? And how do you provide mental health assistance to the community, students and healthcare workers? Because COVID-19 takes a huge toll on mental health. So it's 2 questions there: the role of the Red Cross in community health education, and how mental health assistance is being provided to the community.
Yes, thank you very much. For the Red Cross, they are part of the system from the beginning of the outbreak. They do participate in the community education, mobilizing and sanitizing the community. And recently, we are planning to involve them even to involve them in the screening or testing of the COVID. So they play, I may say their main role is doing the surveillance, detecting the case, educating them. But as I said, the way forward for the last slide, where I said that the way forward is to use the existing structures. So we are going to use, they are part of the existing structure in the community. We are going to use for this home isolation. But they participated a lot under surveillance. Contact tracing is part of the system.
Okay.
So the mental health.
Yes, go on.
The mental health, I may say, we have not been doing that much, but is a key also to the, especially for post-COVID. Recently, we received our colleague from other departments from the council. So we are planning to work with them together to see how we can be we can assist our client. And for the under the way forward, the last slide, I said we are going to decentralize this home quarantine and home isolation. This is where we are going to use our social workers. We have social workers in each village. So there will be a way, some indicators to further them to be following each and every client in their area and to know the social problem they have in the community.
Okay, thank you so much, Dr. Mukadi. We are also joined by Dr. Moyo, who is a virologist and would also like to make a comment in relation to Chobe. Dr. Moyo.
I saw a question about clustering, and I just want to appreciate the work that the Chobe team they've done in terms of making sure they map their cases, and the sequencing that was done this side, really highlighting possible introductions from the borders. And I think you might have seen from the work that we showed last week. I don't know whether you can see. Can you see?
Yes, we can.
It's coming up.
Yeah,
Yes, it's up now.
What he was describing, most of the cases in the schools, as you can see, they represented viruses that were really clustering together, and which shows that there was probably linked transmissions, probably an event or something that could have happened around those cases. So you can see that it was really a community level transmission. As you can see, they're clustering among themselves. And also you'll see that because it's a transporting route, it's not a surprise that the Delta cases in Palape, Martin's Drift, there were 2 cases from the border and 2 cases from the community that are somehow linked to the cases that we also see in Kasane. So the Kasane color is this one. So it really highlights that these are moving all over. And you can see, if you look at Gaborone cases, they are really indicating internal transmissions. And you can see there's a Kasane sample here clustering with a source in Gaborone, showing that they are linked transmissions. And I just wanted to highlight that point, and that his hypothesis of introductions from the border is supported by the phylogenetic data. That it's possible that the border transmissions, because he mapped that some of these cases, 1 or 2 of them were from the border side, and most of these really, it highlights a possible route of transmission that could have come either via the route, tracking route, as you can see here, these 2 cases here, or a link with Gaborone. Some of our original Delta cases really came from Gaborone, possibly because of that link. So that's really I wanted just to show you the work that Kasane has done is really fantastic work, and this is some of their phylogenetic tree showing some of their transmissions. Thank you.
Yes, Doc, it's really excellent work, and we appreciate what they are doing. I think also when we are thinking about border introductions, we should also think about potential illegal immigrants, especially through the border, through the road borders. That could be another potential source of transmission. So I'll take one last question. It's a question from Oweto. I'm afraid to pronounce your surname. I'm afraid I'm going to mispronounce it. So what's this question is saying, what is the plan for post-recovery? Because most COVID-19 patients who have recovered suffer from long-haul symptoms such as fatigue, body pains, brain fog, gut issues. Is there a team of experts studying these long-haul issues? I think that's this one you can just answer particularly to your district.
So thank you very much. As we are Christian, and this is why we see God is helping us to this outbreak. To be honest, for now, we are not doing much on the post-COVID, but it's a way we are going to, because like you said, we have many complaints post-COVID than the COVID itself. and they are grounding even our facility for the same symptoms as before COVID. But it's something already on our table in our plan to see how we can handle this post-COVID, especially that we want to decentralize. Because remember, I said for the next 1 or 2 weeks, we want to decentralize all this follow-up at the facility level, at the village level. So from there, we can take it from there. Because as of now, the health system is overwhelmed, and we cannot cope. We are not coping with the situation, but we will look at it.
Okay, thank you, Dr.
Thank you.
And if you can, please look at how you can also involve the already home-based care workers that we already have, how we can use those as well for home isolation monitoring. Modisa Motswaledi, you can say your question.
Afternoon. Thank you very much for a wonderful presentation. I just wanted to make a comment on the border, your cases between June and July. And I think it's similar to the experience that Tlokwe border had. They had a lot of cases at the beginning of people who were coming in with seemingly a valid PCR that failed when the antigen testing was done. And as soon as they started implementing that, that testing strategy, suddenly the cases disappeared. The fake PCR tests began to reduce. So that is something very commendable, and it's a pattern I think that I'm seeing again here. And we thank you very much for that piece of work. Thank you. Thanks for sharing that.
Thank you, Ramotswaledi. I think that brings us to the end of our webinar today. Thank you very much, Dr. Mukadi, for sharing your experiences with Chobe. We got to appreciate the special challenges that you are facing there, having 3 countries bordering your district there. I'd also like to thank all the participants, everyone who has joined us today. I don't see Dr. Gaolathe here in the participants. Dr. Lebilonyane, I don't know if you want to say any last words. And Dr. Lebilonyane, are you with us? Okay. Okay, she seems not to be with us. Thank you very much for joining
here,
us.
it's just that I needed to unmute. But
okay, Emma.
Yes, Dr. Gaolathe is not with us. I think she lost 2 relatives due to COVID. As we are all, is either we are infected or affected. It's a very difficult time. But thank you very much. Now we had very excellent presentation. We are coming home, closer to home. And really, when we work like this, it really shows that we do have some expertise in country and can be able to explain what we are doing. So I'm really excited. I'm hoping to see more of the district presenting, sharing with us, and also their challenges. I think the challenges that Kasane mentioned are real, and those who know the flights, we don't have our regular flights are not very regular, and Kasane is too far for a patient even to be driven to Gaborone. So these are realities that really, if we said we need to decentralize services, but those services, they should be able to assist patients as much as possible. So I hope that these are some of the things that also the ministry is noting, all as a group, we are all noting, and we see how we can assist, because the districts are different. You have different challenges, but we really appreciate. Thank you very much. And sometimes you don't wait for us to approach you as a district. If you feel like you are burning inside that you want to share with us, let us know. You have Vusi's email. Let us just know that you are ready to present and share what you are doing, your good work that you are doing. And I will encourage you, the district, to document. We need more papers of what we are doing. Learning from the HIV, we did a good job, but we hardly produced any papers from ourselves. So really, this is a way of growing. What you are doing is excellent job. So needs to be shared with the rest of the world. Anything that is not shared, then is not useful. Thank you.
Thank you so much, Doc. Next week, we'll be having a presentation by the WHO, someone from the WHO Botswana office, Dr. Allen, who will be talking about the COVID-19 resurgence planning. See you next week. Thank you. Bye.